So moving on to our topic, it's on diuretic prescription, finer aspects. So just a quick recap of our pharmacology class. I'm not going much into the pharmacology session, but just to know the site of action of each diuretics we are using. We know the carbonic anhydrase inhibitors, they act on the proximal tubule. And the most significant or most commonly used diuretics, loop diuretics, acting on the thick ascending limb of loop of Henle, blocking the sodium-potassium chloride channels. Then we have thiazide diuretics acting on distal convoluted tubule, blocking the sodium chloride co-transporters, which are thiazide sensitive. Then we have the diuretics, which acts on the collecting tubules, collecting that diuretics, including the inact channel blockers, amiloride and triamterene, as well as the mineralocorticoid receptor blockers, spironolactone, eplerenone, and phenterone. So this is an overview of the various diuretics and where they exactly act on our renal tubules. So moving on to the action of diuretics, as I told you, loop diuretics acts from the intraluminal side on 1 sodium potassium 2 chloride channels. So these are not actually filtered into the lumen, they are secreted. So to secrete to the lumen, these diuretics which are bound to the protein will have to cross through the organic anion transporter. So through these channels, they are transported from basolateral side to the lumen of the proximal tubular cells. So both loop diuretics and thiazides are transported via organic anion transporters. So what happens in CKD? In renal failure, there will be less concentration of loop diuretics inside the lumen. Why? Predominantly because one, the number of viable tubules are less. Another one, in uremia or in advanced renal failure, the uremic toxins accumulate. There are several organic anions like p-cresol sulfate, indoxyl sulfate. They accumulate and they compete with the loop diuretics for the organic anion transporters. So as a result, the delivery of loop diuretics will be decreased. And another reason, in severe uremia, advanced renal failure, there will be metabolic acidosis, which results in the depolarization of the membrane potential of proximal tubule, and thus the entry of loop diuretics will be restricted. So this picture on the right side, you can see the loop diuretics, they are bound to the protein, which are albumin, and these loop diuretic bound to albumin through the organic anion transporters, which are in the basolateral side of the proximal tubular cells. They enter the tubular lumen and then they act down segment on the thick ascending limb loop of Henle. Now, when there is advanced renal failure, the uremic anions accumulate and they also will compete for these organic anion transporters, and thus the delivery of the loop diuretics will be reduced. Now, moving on to the first poll, I hand over the session to Dr. Sonu. Thank you, Sonu. So now this is a scenario where we have a patient who is on loop diuretics, not responding to the drug, edema still worsening in spite of the dose escalation. So what to do next? First step, monitor the salt intake. Patient might be on higher salt intake, and that might be the reason why he is not responding to the dose escalation and edema still persisting. Now, what happens when the patient is on high sodium diet? There is something known as renal adaptation. If a person has a chronically high sodium intake, the downstream nephron segments can adapt over time and they increases their sodium transport capacity, and there will be more reabsorption of sodium that the loop diuretics is trying to excrete. So basically, there will be a compensatory reabsorption due to this renal adaptation. And there is something known as post-diuretic sodium retention. See, loop diuretics, especially furosemide, they typically have a short duration of action. So during the drug-free interval between the doses, the kidneys aggressively reabsorb the excess sodium from high sodium diet. And this is known as post-diuretic sodium retention. And this can completely offset the sodium and fluid loss achieved during the diuretic's peak effect. So this will result in no net fluid loss over 24 hours. So this is why the salt intake should be monitored when you are encountering a person with refractory edema. So this is something which we all know. One who eats salt will drink water. Malayalam we say uppu thunna vellam kudikum. So salt is very important. Salt restriction needs to be ensured. Now, after that, what is the next to do? It could be a diuretic breaking. See, what is it? Distal tubule will undergo hypertrophy or remodeling when the patient is on long-term loop diuretics. So because of the long-term sodium potassium chloride blockade in the loop of Henle, there will be an upregulation of the sodium chloride co-transporters in the DCT. There can also be a compensatory increase in INAC channels in collecting duct. Now, how to overcome this situation? Go for sequential diuretic strategy. Combine two types of diuretics, that is, two different diuretics acting on two different segments of the nephron. So this is otherwise called diuretic synergism. See, synergy is like, in maths, 1 plus 1 is equal to 2, but here it is having effect more than 2. So some sort of sequential diuretic strategy will be helpful. So along with loop diuretics, we can add thiazide or metolazone thiazide-like one, chlorthalidone, or mineralocorticoid receptor antagonist. Now, what is the role of metolazone? So majority have given their option as to add metolazone to the loop diuretics. See, all thiazide and thiazide-like diuretics, they are not filtered just like loop diuretics. They need to be secreted into the lumen through the organic anion transporters. Now, as GFR decreases, its secretion reduces. But the advantage of metolazone over other thiazides is that they have high potency, good oral bioavailability. So even if low eGFR, it can compensate. Let's see the role of chlorthalidone in advanced renal failure. So as Sonu rightly told, our previous concept was if the eGFR is less than 30, we will avoid thiazide. And if at all using, the one which is preferred classically is metolazone. Now, after the CLIC trial, so CLIC trial is not exactly assessing the diuretic response of the chlorthalidone. It is actually for assessing the effectiveness of chlorthalidone as an antihypertensive agent in advanced CKD. So what they did is they did this study in CKD stage 4, and they found that the chlorthalidone is effective in controlling hypertension in advanced renal failure. So that means there is some evidence that chlorthalidone is effective in advanced CKD. So thus, we can consider this as one of the drug in our armamentarium for sequential blockade as well. So this is a CLIC trial published, and this is actually done in stage 4 CKD and finding its effectiveness as antihypertensive. So the study found that among the patients with chronic kidney disease and poorly controlled hypertension, chlorthalidone therapy improved blood pressure control over placebo. So that means chlorthalidone has effective role in advanced CKD as well. Now, if you need further augmentation of action, we can add INAC channel blockers, directly acting ones like amiloride, or indirectly acting one like mineralocorticoid antagonist, spironolactone, eplerenone. And these agents are preferred, especially if the patient is having heart failure or if their potassium is on lower side. We know these are potassium-sparing diuretics. So if patient is already having hypokalemia, along with loop diuretics, you can add these drugs for further augmentation of the action. Now, so if diuretics are not acting, use this checklist. So when you're facing diuretic resistance, first of all, make sure your diagnosis is right, whether there is actual volume overload. Sometimes venous stasis, lymphadenema can be mistaken for volume overload. The next important thing is non-adherence, whether even non-adherence to medication as well as non-adherence to salt restriction can result in edema worsening. Then another one is decreased drug delivery. This is seen when there is gut edema, which can result in decreased absorption, inadequate dosing or frequency, and hypoalbuminemia. I already told the diuretics, the loop diuretics bind to albumin. So if there is hypoalbuminemia, their delivery into tubules are restricted. Now, another cause is decreased drug secretion because of the decreased blood flow due to AKI. And tubular transport inhibitors, as I already told you, the uremic toxins like indoxyl sulfate, p-cressyl sulfate, competing for the organic anion transporters or other bile acids, organic acids can decrease drug secretion and decrease kidney response when there is distal tubule hypertrophy and RAS activation secondary to the volume depletion and resulting in rebound edema. Now, coming to the pharmacokinetics of loop diuretics, I'm not going in much detail, but just what we need in a clinical practice. Furosemide and torsemide, they are absorbed relatively quickly after oral administration, and peak concentrations will be reached within 30 minutes to 2 hours. And when given intravenously, effects will be nearly instantaneous. Now, coming to the oral bioavailability, there is some difference between the various drugs in the loop diuretics. Furosemide has a lower oral bioavailability. It's around 50 to 60%, whereas other loop diuretics like torsemide, it is more than 80 to 90%. Now, this difference in oral bioavailability has implications when we make conversion IV dose to oral dosing. So furosemide dose should be doubled. For example, if you are using 20 mg of intravenous furosemide, when we convert to tablet, it should be 40 mg of tablet. Whereas torsemide, we can go with the same dose. IV and oral, we can have the same dosage. Now, when there is GI tract edema, the velocity of absorption will be decreased. Although the total amount of drug absorption won't be affected, but because of the slowed absorption, this will prevent the oral furosemide from reaching its threshold plasma concentration. Now, once absorbed, the most diuretics are bound to the serum albumin for distribution. So in case of hypoalbuminemia, there is decreased diuretic delivery. And to overcome this, to get the good drug response, it's better to combine IV albumin and loop diuretics as co-infusion. And then thus we can improve the drug delivery. Thank you, Sonu. So moving on to our next area, whether to go with continuous infusion of the diuretics or IV bolus infusion frequently. See, regarding the IV infusion, IV bolus of furosemide, there will be a rapid increase in sodium excretion after giving an IV dose. But maximum excretion will be for first 1 to 2 hours, and then it progressively declines. So the peak natriuretic effect with second dose is actually 25% less than that of the first one. Now, the post-diuretic renal sodium and fluid retention can occur. So there is a compensatory sodium retention which occurs along the other nephron segments. And to avoid this compensation, either you have to inject the loop diuretics furosemide at shorter intervals, at short frequent intervals, or to be given continuous infusion. Now, regarding the continuous infusion, it maintains an effective inhibition of sodium reabsorption over time. And some studies have shown this is associated with less ototoxicity, but we need further studies on this aspect. Now, maximum diuresis occurs 3 hours after continuous infusion has begun. So if we are giving furosemide continuous infusion, we need to give an IV loading dose to increase the initial intratubular concentration of the furosemide. Now, the recommended loading dose is 40 to 200 mg according to the renal function, and the infusion rate is around 10 to 20 mg per hour, which can be increased to 40 mg per hour. Now, when I search the literature regarding the comparison between these two modalities, see, most of the comparisons are done in cases of acute heart failure, and it was a mixed result. Just like our poll, there is no concrete evidence to show one is superior to other. So this is one systematic review and meta-analysis which showed there is no difference, but they have found there is some increase in diuretic effect with continuous infusion. And this is another article which is again the study done in heart failure, which showed that continuous versus IV bolus infusion, IV bolus regimen, no significant difference. So this is a meta-analysis which is supporting continuous infusion as a better one after giving a loading dose that resulted in greater diuresis. Then, but again, another meta-analysis showed there is no difference in urine output. And these are some of the randomized controlled studies which is supporting continuous infusion. Some are showing it has better diuresis and less ototoxicity, but we need more studies. And yet this is another one showing there is not much difference. So basically, it's like a 50-50. They're saying there is no concrete evidence to say one is better or other. But the issue with continuous infusion, as we can see, practically the patient is tied to that IV infusion thing throughout the day. So with compliance and patient comfort. So when we consider all these things, it will be better to go for an IV bolus regimen rather than continuous. But anyway, let's see what the... Okay, so addressing our question, if the patient is having residual renal function, how long to continue loop diuretics? See, as Sonu rightly told, many of our patients are following incremental dialysis. So basically, we cannot generalize this question to all. It's basically an individualized approach. So when patients are following incremental dialysis, controlling volume status is important. Now, one thing we have to be very clear, diuretics will increase urine output and will control the volume status, but it will not result in clearance. So for the actual dialysis clearance purpose, we cannot resort to diuretics, but when following incremental dialysis and when many are under twice weekly dialysis, so to avoid frequent episodes of pulmonary edema and volume overload state, we can resort to diuretics. Now, how long to continue? See, if as long as the patient is having good diuresis and everything is well, we can continue. But the question is, when to stop this? Do we have to continue if the urine output is less than 200 ml? So my personal opinion, just like the poll result had showed, when the urine output is less than 200 ml, there is no meaningful difference in giving the diuretics. And another thing, at this level of renal failure and with this much residual urine output, now we have to give high doses of diuretics, which we know high doses can result in ototoxicity. So we don't get the benefit, and maybe after a few months or 1 year, we'll be pushing the patient to deafness. So we can consider stopping diuretics if the urine output is less than 200 ml. And as we need high doses at this time and side effects and ototoxicity issues high, so it's better to stop at that time. I think we'll get the expert panel opinion also in this aspect. So over to Dr. Sonu.
Sadish Balan, sir, could you please enlighten us on your practice patterns in diuretic usage in individuals with dialysis?
Yeah, I think what Dr. Jyothipriya summarized is actually what is we are all practicing. So generally in patients who have some urine output, I won't say 200. 200 seems to be a little low for me, but maybe a little more than that, maybe around 500 ml, I would give diuretic, especially as we are doing twice weekly dialysis or less than that. And that helps to maintain urine output. There is an old this thing, what we used to learn in our old days is that urea clearance depends upon urine output. And it is maximum at 2 ml per minute of urine output. So that means around no, so 1 ml per unit. So that means about 2000 ml per day. That's how it's a maximum urine output. And that is where you get a maximum urea clearance. It varies a great deal between 25 and 75% of GFR. So that way it is there. And the other confounding factor there is if you have volume depletion, then urea clearance will come down. And that is not a feature that is there in most of our dialysis patients. So therefore, diuretics will help not only to increase urine output, but also some amount of urea clearance, because the urea clearance will increase because the urine output is more, and because there is enhancement of urine output because of the increase in the urine output itself, which is one of the major factors for urea clearance. So even though Dr. Jyothipriya said that it doesn't really increase the clearance, it does help a little bit of increase in urea excretion as per these thing, unless the patient is volume depleted. Of course, there are a lot of other factors which come into play, but I like to see that it is actually doing a bit of help. So that's why I do use it, diuretics, but the urine output is low, I stop it. But some of the patients are reluctant to stop. And I have a patient who's taking Lysis 1 tab daily for the last 5 years for no reason, but I can't stop it because he refuses to stop. So that also happens.
Thank you, sir. Thank you for the expert words. And medicines have two sides actually. One over which have effects, which will also have some side effects. So diuretic therapy will have some complications, and I would like to ask Jyothipriya to enlighten us on the different complications of use of diuretic therapy.
Okay, so when using diuretics, there are certain safety concerns also associated with it. The important one is electrolyte disturbance. We all know the various electrolyte abnormalities that can happen with diuretic use. The predominant one is the sodium disturbance. And thiazides, they're notorious to cause hyponatremia, especially in elderly. Loop diuretics, it can cause both hypo and hypernatremia. Hypernatremia happens because there is increased free water clearance by affecting medullary concentration, and hyponatremia when there is volume depletion, rise in ADH, and that can result in hyponatremia. Now, next abnormality which we frequently encounter is hypokalemia, which is associated with the usage of loop diuretics. But in fact, in CKD, this can be beneficial, especially in advanced CKD, where hyperkalemia is a predominant problem with these patients. Now, hyperkalemia can happen with potassium-sparing diuretics. So most of the times, the combination of these two might tackle the issue. Then hypomagnesemia is seen predominantly with loop diuretics, and to some extent is also seen in thiazide, especially with high doses of loop diuretics. Then metabolic alkalosis and hyperuricemia are other issues which we face. But in clinical practice, one of the most important things we face is worsening of renal function. Now, when we start diuretics for a patient, of course, there will be some elevation of creatinine. We say it is like a diuretic-induced permissive hypercreatinemia. So it's like some elevation is acceptable, but there can be severe worsening as well. So there are two causes, etiologies for this severe worsening. One is the inadvertent usage and volume depletion that can lead to pre-renal AKI. But this can be easily mitigated by actually teaching your patients how to self-titrate the diuretic dose, especially in an OP basis. We can ask them to assess their edema, though I'm sure edema is not exactly a indicator of volume status, but at least they can titrate the doses to some extent and mitigate this problem, and use only if there is edema C. And another reason for severe worsening or rapid worsening of renal failure is acute interstitial nephritis, which is not that common. So these are the two conditions where which can result in renal failure worsening, and one situation we have a trouble in continuing the diuretic. Then another one is with ototoxicity with the loop diuretics high doses. So, but generally we are not that frequently encountering this issue, but in high doses, this is possible. So I'm handing over the session to Sonu for getting the opinion of the panel regarding the issues they have faced.
Jamina ma'am, could you please enlighten us on the monitoring strategies that you use to avoid severe electrolyte disturbances and renal function worsening with the diuretic usage in outpatient basis? In inpatients, we usually monitor the renal functions at least once in 2 days. So in outpatient basis, when you are escalating the diuretic dosages, how frequently you monitor all these things?
Yes, Anu. Basically, we have to actually be aware to whom we are actually using it. So if you're starting in an elderly patient who has got a very small body frame, and especially when they are hypothyroid or on multiple other drugs, we have to be very careful, especially when we are actually starting on thiazide diuretics, because they are prone for developing hyponatremia, especially if their intake of protein is also less. We have to be very much aware. And usually easily missed thing is hypomagnesemia. It happens both in loop and in thiazide diuretics. So we should be on watch for development of hypomagnesemia, because this leads to arrhythmias and many other complications like hypocalcemia and worsening of hypokalemia. So actually, these patients should be closely monitored when we are actually starting on diuretics. So the commonest thing what we get is that with loop diuretic is hypokalemia. So these patients usually present with muscle cramps, small alterations in their symptoms like muscle cramps, polyuria. All these things should be closely watched to detect early changes. And you should always have a baseline ECG to check whether they have any ECG changes of hypokalemia and symptoms of muscle cramps, fatigue, and always check for their edema status also. Decrease the dose as soon as their edema decreases. These are the ways we can actually check the usage of diuretic and its complications.
Thank you, ma'am. Thank you for that excellent answer. Jacob Joseph. Jacob, sir. Jacob, sir.
Sorry, I agree with most of the things I said. I'd just like to add one more point is, especially if patients are on SGLT2 inhibitors also, along with diuretics, like patients with diabetic nephropathy, we often combine diuretic, mineralocorticoid antidepressants and SGLT2 as per guidelines. And we should always tell these patients that if at all you develop any evidence of situations where you're likely to go into volume depletion, like a diarrhea or something like that, then you should definitely skip the diuretic dose. That also I think should be highlighted to patients, especially if they are on SGLT2 inhibitors.
Thank you, sir. Now, diuretics are not only used for the management of fluid overload in chronic kidney disease, it is used in some special situations also. We would move on and see those special situations now.
So coming to the usage of diuretics in special situations. So I'll start with nephrotic syndrome. Do we actually need a diuretic in nephrotic syndrome? In spite of hypoalbuminemia and intravascular volume depletion, we may have to use it judiciously to control the edema and extracellular fluid overload. So the problem is here we have to use it cautiously because this can result in pre-renal AK as well if we are not using it judiciously. Now, there are certain barriers for diuretic action in nephrotic syndrome. One, in nephrotic syndrome, there will be gut edema, and because of that, the oral absorption will be poor. Second thing, hypoalbuminemia. So as I told you, this loop diuretics will be binding to the albumin, and this bound form will be delivered into the tubules. So because of hypoalbuminemia, the loop diuretics are not cleared properly. So it will be cleared easily because of the low albumin. So in hypoalbuminemia, there will be decreased delivery of loop diuretics. Now, how to tackle this situation? So combining IV loop diuretics with IV albumin will be a feasible option. So for example, we can combine 40 mg of IV furosemide in 100 ml albumin, and infusion could be done for 4 hours to tackle this situation. Now, second one is the use of diuretics in hypertension. Now, in this scenario, the one important rule is do not use loop diuretics unless there is volume overload state. So restrict the use only for volume dependent hypertension. So many times I have seen physician prescribing loop diuretics for controlling the blood pressure without any volume overload. So if you use in a non-volume overload state, this can lead to volume depletion and secondary RAS activation, and that can lead to rebound hypertension as well. Then the commonly used diuretics in our practice to control blood pressure are the thiazides, hydrochlorothiazides, indapamide, and chlorthalidone. We can also use mineralocorticoid antagonists like spironolactone, eplerenone, especially if there is resistant hypertension, because we know many of the times a person having resistant hypertension may have diagnosed or undiagnosed hyperaldosteronism. So this could be beneficial in that aspect. And one additional advantage is these agents will prevent the myocardial and renal fibrosis. So this could be, these are the, we can use thiazide as well as mineralocorticoid antagonist. And regarding chlorthalidone, now the CLIC study has shown in advanced renal failure also this chlorthalidone is beneficial in controlling the blood pressure. Now, one advantage of chlorthalidone over other thiazide is that chlorthalidone is markedly concentrated in the erythrocytes, in the red cells, and subsequently they equilibrate by a slow diffusion back into blood. So they have a longer duration of action compared to our hydrochlorothiazides and other thiazides. So this is one added benefit, and they can be used in advanced renal failure as per the related studies. So when you are combining diuretics with RAS blockers, there is a synergism. We can attain a synergistic action. Combination with RAS inhibitors, there augments the action by prevention of RAS activation, which can be due to this usage of loop diuretics. So this is one special advantage in combining. Now coming to the use of diuretics in heart failure, it reduces the preload, and diuretics, especially loop diuretics, has a direct vasodilatory action. So it is beneficial in heart failure. So how do loop diuretics produce vasodilatation? One, they act on vascular smooth muscles and inhibit the sodium potassium chloride channels in the vascular smooth muscles. And intravenous administration of loop diuretics, they trigger the release of nitric oxide from endothelial cells, contributing to the venodilatation. So this venodilatation reduces the venous pressure and is beneficial in heart failure, and it decreases the workload on the heart. So moving on to the discussion part, Dr. Sonu.
Dr. Anjana, actually now left and right every patient is on SGLT2 and the evidence is there for the usage also. Now, how do you balance a diuretic with SGLT2 in patients with CKD and heart failure? Jacob sir has already pointed out that it has to be avoided in a sick day. Please give us some finer points on this.
Thank you, Sonu, for the question. So I think just as you said, there is enough evidence for us that is showing us that in a patient who has got heart failure and CKD, as long as the GFR is above 20, it is safe to use a SGLT blocker. But the problem is it is also a diuretic. It is also a natriuretic. So there is always a synergistic action, just like with loop and thiazides. So this is a point that has to be kept in mind, like when you're starting a patient, a combination of loop diuretic and SGLT, because there will be a synergistic diuretic or natriuretic action. But at the end of the day, SGLT is always renoprotective. So maybe reducing the dose of the loop diuretic when you're introducing the SGLT would be one strategy that we can follow when you're actually putting patients on both together. And this should again be with the help of volume assessment of the patient with multiple tools, along with clinical examination, along with use of NT-proBNP, chest X-ray, and a VETSIS or a POCUS. With more tools being available in our hands, I think we should make use of IVC, hepatic congestion, renal congestion. So all these could be put together to assess the volume status and decide on whether we should reduce the diuretic dose when you're introducing an SGLT. So it's always a balance. And at the end of the day, we all need decongestion along with an acceptable rise in creatinine. So a permissive hypercreatinemia at the expense of decongestion, it should be the balance when you're treating patients with CKD and heart failure.
Thank you, Anjana. Thank you for that clear answer. Now we will quickly go through the other situations, and we have only 5 to 10 minutes left. So
thank you, Sonu. So now just a quick rush over the other situations where we use diuretics apart from all this volume overload, edema, hypertension. One is in renal stone disease. Thiazide use has been a common practice for several years and decades. Now, after the no stone trial, there is some change in the approach. So the no stone trial had shown among patients with recurrent kidney stones, the incidence of recurrence did not appear to differ substantially among patients receiving hydrochlorothiazide versus placebo. So in fact, as per the latest trials, we have to judiciously use or individualize our approach in using thiazides as part of renal stone disease management. Now, other use is in hypercalcemia management because loop diuretics increases the calcium excretion. But the problem is these patients with hypercalcemia already having polyuria, they will be volume depleted. So further addition of loop diuretics can push the patient to more volume depletion and worsen the AK. So it is advisable to depend mainly on hydration and other hypercalcemia treatment option preferably, and restrict the use of loop diuretics as far as possible. Now, just the last slide, just for a clinical practice help. See, we use torsemide and furosemide left and right. So just a dose conversion strategy. So as I already told you, furosemide has a shorter duration of action. We need multiple doses, frequent dosage, and the oral bioavailability is only 50%, whereas torsemide has a longer duration of action with an oral bioavailability of around 90%. So when we are converting 20 mg of IV furosemide to TAP furosemide, we have to double the dose. So 20 mg IV will be equivalent to 40 mg of oral dosage. And whereas torsemide, 20 mg will be same as tablet will also be 20 mg. Now, IV torsemide is 2 times more potent than IV furosemide. So if you give 40 mg IV furosemide to convert to IV torsemide, 20 mg will be sufficient. And oral torsemide is 4 times more potent than oral furosemide. So 40 mg of furosemide, it will be equivalent to 10 mg of torsemide. So if you are giving 100 mg torsemide, we have one single tablet and give. But if you are converting into a 40 mg furosemide, you may have to give 10 tablet and